The debate is about the interaction between the blood cells, the bone cells, and the implant surface.
So you already have this bone that has been already traumatized by the drilling process. There's trauma, no question. They will need a turnover and remodeling just by that fact. And then you squeeze that cork.
Yeah, because people insertion torque. I want an 80 Newton insertion torque. It's counterproductive.
It's counterproductive.
This year marks a very special milestone for Straumann, the 20th anniversary of SLActive, a surface that has truly redefined the way we think about implant osseointegration and long-term outcome. I had the privilege of speaking with Professor Shakeel Shahdad, one of the leading experts in implant surface, who shared his clinical and research journey and why you too should trust your patients with SLActive surface implants. Don't miss this conversation. I'm Dr. Christian Jahi, and this is Straumann Pro Talk Clinical.
Professor Shahdad, what an honor to have you with us.
Christian, thank you very much. Very, very flattering introduction. It is an absolute pleasure for me to be here with you and spend the morning sharing some experiences and thoughts with you.
Oh, I can't wait to see where this conversation will go.
Now, what's incidental is you just mentioned 20 years of SLActive. Incidentally, my journey through Straumann and SLActive is also 20 years this year. So, in a way, I feel we have kind of grown together. I have matured with SLActive over the last 20 years. And during that journey, have gained immense experience in terms of what an implant surface can do for us and our patients. So I'll be delighted to kind of share my thoughts and experiences and knowledge with you guys in terms of what we've done, what I've learned over the years, and also the experience of our recent research studies.
And we deeply appreciate you coming. And by the way, happy anniversary then.
Thank you. Yes, indeed.
So we set the pace here. We still hear often people couldn't care less. They just want an implant to be placed. And sometimes people take for granted the importance of an implant surface. For all the colleagues out there that still take for granted, how do you define, let's set the basis, right?
Yeah.
The fundamentals. How do you define the implant treatment process, and why does it matter? This is something that I really need to, first things first.
I think we need to, once we appreciate that we're actually placing a foreign body in a patient's mouth.
Wow.
Yeah. And in my opinion, implant surface does matter. We've always known in terms of, if you look at casting back and sort of seeing the implant surfaces, how they've evolved over time. The various alloys, it didn't work as well as, commercially pure titanium. And the debate doesn't necessarily need to be it's not just about between the rough and the smooth, and not between how is an implant surface made rough. The debate is much wider than that. The debate is about the interaction between the blood cells, the bone cells, and the implant surface. What triggers a process of osseointegration, and whether we can modify that in our favor. When I say our favor, I'm talking about both me as a clinician and my patient as a recipient of that device, shall we sort of say. So therefore, the implant surfaces are absolutely essential because, what we did with implants 20, 30 years ago is very different to what we do with implants today, because we have, over the years, gained so much confidence with what we can do with our implants, and then we're pushing the boundaries. And if we're pushing the boundaries, whether it's immediacy, whether it is surgical sites with significantly deficient bone, or, having to push those boundaries means we need the tools to be able to support that as well. And that goes in implant surfaces, that goes in implant designs, biomaterials that we choose. So as clinician, I believe we have a huge responsibility in terms of making sure that we make the right decisions for our patients. Because patients don't come asking us to place a specific implant, a design, a surface, length, diameter. They just want a tooth.
Yeah.
Yeah, we make those decisions.
They couldn't care less about a beautiful suture.
Nobody, I've never had a patient come in to sort of say, hey, I want a Straumann SLActive bone level or tissue level 8 millimeters. No, they say, I've got a problem, please solve it for me.
I like this very much, how you contextualize and how the surfaces play a big role, because honestly, the problems won't change.
No.
Better tools will make a difference, and you have to be better equipped for this.
Yeah.
And speaking of, you want to say something? No. Speaking of anniversary, right? 20 years. In your opinion, the cases you have seen, why do you think the introduction of SLActive 20 years ago was such a turning point in implantology?
It goes back to the basic science. When you place an implant, we talk a lot about primary stability in implant dentistry, and it's always been primary stability has underpinned the overall basics and basis of implant dentistry. And then, that was particularly true when we were placing machined Dänemark implants at the time. And as you know, Straumann has always been rough surface implants, but of course that rough surface has evolved over time. So the secondary stability, or the bone-to-implant contact, is the most critical thing for long-term. Now, I say long-term, which is great, but you also have to question, what do we want in the short term? I'm talking about the first few weeks after placing the implant. That early interaction between the host and the implant surface. And that early interaction is so critical, because you have the moment you place an implant, there is a race. There's a race between bone, and there's a race between fibrous encapsulation. In other words, there's a race between osseointegration and fibrous encapsulation. One, osseointegration means success, fibrous encapsulation is failure. So anything that we as clinicians can choose that can trigger or fast track that early interaction between the blood clot, and as a result of that, the blood cells, the early angiogenesis, early bone cell proliferation, which can trigger that process and speed up our osseointegration, is going to be, of course, beneficial for us, because then we're not really relying on primary stability. Primary stability gives that initial confidence, but that's not enough, because implants fail if they don't achieve secondary stability. In other words, if they don't osseointegrate. Okay. And those few early weeks are very, very critical, particularly in cases which are aggressive, shall we sort of say, cases, which include your extraction sockets, which include your pretty big bone defects.
Right.
We have gained so much confidence over the years in terms of what we do with bone regeneration around implants. I mean, the days when every case would get a block graft and people would have to have their hip sacrificed for putting implants in the mouth, those days have changed. And that's only come because of the confidence that we have with guided bone regeneration, for example. And talking about guided bone regeneration,
right.
The implant surface, like an SLActive surface, we know from evidence, is an osteopromoting implant surface. So it not only is helping you achieve quicker osseointegration with the host bone, it's also at the same time helping promote the new bone formation through the GBR process.
Right.
So it's we also know, I'm talking a lot about SLActive at the moment, but we also know that other implant surfaces, rough implant surfaces, if you give them enough time to heal, they will reach the same level of stability and secondary stability.
Over time.
Yeah. It's that initial race. I often, in my lectures, I often talk about this is like a 100-meter sprinter, Usain Bolt, versus a marathon runner, Mo Farah. They both will win a gold, but one is a lot quicker than the other one.
Shaq, I would say, you see, I already dropped the professor, right? You're already Shaq.
Thank you for making, the professor title makes me feel a lot older than I actually probably am.
You just hit the nail in the head, because we often talk to clinicians and there's a bit of a skepticism. They say, well, oh yeah, how would a surface help me in immediate solutions? How would that help my primary stability? So you're right, you won't.
Yeah.
But you took so much care engaging your implant in the right position, respecting three-dimensional positioning. You took so much care creating that beautiful emergence profile for that patient to go home. And now it's not under your care. There's so much a patient can do when it's released back home, like whatever that is, that the behavior or that could trigger a potential or could jeopardize all the precious therapy you just applied, that you want your secondary stability to come as quickly as possible to kick in. And that's a turning point. So when I reflect about the role of SLActive, I mean, how do you see this affecting the decision-making process in such an indications that we were not so familiar with in the past? Now we are, and how such a tool in your toolbox changing the decision-making process. For example, as you just said, immediate solution is one that will be compromised patients, and we may touch on that one, but sometimes we don't even know the patient is compromised.
Yeah.
Right?
Absolutely.
How you see the surface as an added adjunct value in this therapy?
Yeah. I mean, let's pick up immediate implants in an extraction socket. A simple, well, that's actually a wrong word to use, simple. Let's call it people consider, central incisor an easy, from an immediate point of view, they feel it's easy. It's far from that. But let's pick that as an example. Now, the reality is, if you're going to get your implant in the correct place for a central incisor as an immediate, most of your implant on a facial aspect is not in contact with the bone, should not be in contact with
It's naked.
Yeah. It's the apical few threads, whatever you have, whatever space you have or height you have available above the apex of the implant is what gives you that primary stability. And often we forget that most of that implant has no contact with the bone, is not engaging, the threads are not engaging. So therefore, whilst we have primary stability, that primary stability is provided by the few apical millimeters of that implant, not the whole length of the implant.
Right.
And we often forget that. What that means is, if you, from a surface area point of view, if you sort of say, okay, now if you look at surface area point of view, a vast surface area of that implant is not in contact with the bone, and we place some bone graft in between. So therefore, as the primary stability drops, which we know it drops over a period of first few weeks, and the secondary stability starts to kick in, we need to shift that graft to the left so that the secondary stability kicks in as quickly as possible. Now, that is where the benefit of a active surface like a SLActive surface comes in, because you're getting the confidence that your implant is, sort of say, I tell my patients, look, this is like baking. Yeah, you prepare a dish, you have to put it in the oven, and then the question is, how long do you place it in an oven before it's cooked? The difference is your SLActive cooks much quicker because your oven is a lot more efficient than a non-SLActive surface where it takes longer to bake that dish.
Or make them out undercooked.
And patients understand that language easily, right? You got to make it less scientific for patients, what you mean by healing times, why they need to wait for certain things and stuff. So, we'll try to break it into a language that a patient would easily relate to.
Oh, of course.
And baking is not a bad thing, is it?
Not a bad thing. It's such a good thing. You just don't want anything undercooked.
You don't want anything undercooked. Yes, because it'll end up in the bin.
Exactly. What a great analogy. And in compromised situation, we said primary to secondary stability, right? And added to the fact that I was just reflecting as you were saying, the implant alone is partially in a bone. And also, especially in the aesthetic zone, patients would like to go home smiling. Then you place an abutment and you increase the arm force. Then you put a prosthetic provisional crown. You make the arm lever
longer.
Quite discrepant. I agree with you completely that we should make use of every possible resource to improve the baking.
So what has happened over the last 20 years, at least in my practice and in my unit, is a vast majority of patients that we treat are patients who have hypodontia, patients who are born without teeth. And we know that in such cases, because there has never been that a permanent tooth hasn't developed. So the alveolus is completely underdeveloped. So we end up with patients with pretty severe bone defects. I'm talking about 2, 3, 4 millimeter ridges that we place implants in. Now, in the past, these patients needed quite a significant amount of reconstruction. We're talking about young teenagers having had no teeth, and then a few years of orthodontic treatment. And the last thing they want when they hit age of 18 to now put them through lots and lots of invasive, aggressive surgeries. Right. Bone reconstruction first, soft tissue reconstruction, and then putting implants in. It's a long journey. Yeah? Yes. What we have over the years, the confidence that we've gained with the implant surface that we've used is we have developed our philosophy around a motto, minimizing morbidity without compromising outcomes. What do I mean by that? I mean, there is evidence base, and I like to use evidence base as a benchmark. Yeah, when we quote evidence to our patients, it is a benchmark, because you can't always sort of say, because this is the evidence, we will achieve it. You have to, we're clinicians. And dentistry, implant dentistry, anything in dentistry is dependent on the clinician who is delivering that treatment. So therefore, we need to know our own success rates to be able to quote it to the patients and tell them, in my hands, in evidence is A, but in our hands or in my unit, this is our evidence. So therefore, it's important that we tell the patients what they're expecting from me as a clinician, rather than what is written in a journal. Right. But it is important that we benchmark ourselves against gold standard, and gold standard has to be evidence-based. So when I say minimizing morbidity, put yourself as a patient. Yeah. Let's say you need a surgery. Let's leave dentistry out. You need, let's God forbid, you need a cardiac surgery. What would you want? You want the surgeon to be confident enough to give you an outcome in least number of surgeries, or you want the surgeon to say, "Oh, I need to do 6 surgeries for you before I'm going to get you there." Of course, everybody wants the least number of surgeries, right? And it's the same thing. Our philosophy literally revolves around the same belief that we want to achieve outcomes for our patients with the least number of surgeries. When I say least number of surgeries, I'm talking about 1 surgery. And often our patients require, we place an implant, there is bone missing buccally, there is bone missing palatally, and we do a bone graft GBR palatally, we do a GBR buccally, and we reconstruct site in one visit. So I call it a sandwich GBR, because we're sandwiching an implant between the buccal and the palatal GBR. Now, to be able to push the envelope of GBR to that extent, where you're really, really going against all the grains here, you need the confidence of the tools that you're choosing for your patients. Right. And you cannot afford failures, because, it's going to get you a bad name. Your unit is going to get a bad name. You're going to get a bad name amongst your colleagues. And as they say, often, the most successful practice is one which moves every 5 years. Because you don't see your long-term outcomes. And no accountability. Right? Exactly. So we don't want that, right? So therefore, we have to be mindful of, I want to choose things which have evidence base, but also at the same time, I want to be confident, because I want to, in our own clinical experience, be able to demonstrate that we can push the boundaries here for the benefit of our patients. Yeah. And if we feel, we'll probably come to at some point about the primary stability, and its significance, in my opinion, has always been overcooked in implant dentistry. But then to be able to place implants with compromised primary stability, I'll take it to an extent with no primary stability. Whoa. Yeah. You need to have some belief that there is, for example, SLActive is, if it wasn't for SLActive, I probably wouldn't be practicing the type of implant dentistry I do today. I'll really summarize it that much.
I see.
That over the last 20 years, with every case that we do, the more and more confidence that we gain, I'm truly relying on an implant surface to deliver results for us, and in a way to make me feel good, make me look good, shall we sort of say, because we're doing something which is really aggressive in terms of treatment, but still not compromising our outcomes.
And also to feel good. Come on. I mean, we don't choose dentistry because it's just some random. We really choose because we have a passion for it. We like to deal with people. We like to do good to people, and we like to know that what we're doing, it's an assertive decision supported by partners like industry partners. That is, we are so privileged. I would say that those words you're saying, it really resonates, that all the efforts that an immense amount of team put into from Straumann into research, into development, comes to a final outcome that you're feeling satisfied because you're providing to your patients something that it makes you and them feel happy about it.
Absolutely. And that you cannot, in dentistry, and particularly implant dentistry, you cannot underestimate that collaboration between industry and clinicians. It is a key essential. And the industry has to be responsive to the needs of the clinician and to the feedback from clinicians. That's important, right? They have to work in collaboration because there's only so much experimentation industry can do in their corporate offices and stuff.
Yeah.
Ultimately, the feedback and what works, what doesn't work, has to come from clinicians. And that's why this collaboration is so important.
And we have moved long ways away from all the garbacho implants, the subperiosteal, as you were describing in the beginning, some experimental alloys. Implant dentistry is very well fundamented. Right? That's what I like so much about. Chuck, we have one session in a podcast called It's Not What We Think, It's What We Know. And I ask our guest to highlight one article that you think the dental community should know because it either opened your eyes to something new or shifted your eyes to something that you were not doing and now you started doing. And you nicely shared with me the paper from Frank Schwartz that is quite the standard in research up to this day, how we promote research in implant dentistry. That is, it's an article from 2008.
2008. There was a series of articles.
Right, yeah. This one's published in 2008. Bone regeneration in dehiscence type defects at non-submerged and submerged clinically modified surface and conventional SLA titanium implants and immune histochemical study in such a tongue twisting.
It's a tongue twister, right?
My God.
Yeah.
It feels like those German words, they attach everything together. An immune histochemical study in dogs. Shaq, why is this so meaningful to you that you thought you should share with the dental community?
This study really was a big game changer for me in terms of thinking about how an implant surface on its own can be osteopromoting. It was the first time, when you sort of say, it's about, this is where the evidence base really plays a big important role in our clinical decision making. This was a study where the SLA and SLActive implants were placed in dogs with big 4x3 millimeter dehiscence defects that Frank created. And didn't put any bone graft in. Didn't put a membrane in. Just closed the flap.
Just the defects.
Yeah, well, some of them were submerged, some of them were not submerged. And he compared the hydrophobic to a hydrophilic implant surface. And remember, at that time, there was only one hydrophilic implant surface, and that was the new SLActive implant surface. This concept didn't exist at that time. And what was remarkable was the absolute stark difference between the spontaneous, we're talking about spontaneous bone regeneration in an SLActive defect compared to an SLA defect. And in SLActive, after 8 weeks, nearly 80% of that defect had filled with new bone. Yeah. Now, what does that tell us? That tells us that that tells us how powerful the human biology, in conjunction with an attractive surface to cell attachment, to clot attachment, can be. At 2 weeks, there was a significant difference between SLA and SLActive. In 8 weeks, there was, I mean, when you first see those slides, the histology slides, you can't believe your eyes that you can see so much bone fill in a defect. Yeah, there we go.
Yeah.
You look at that.
It's a lot. It's significant.
And it's hard to believe. And when you compare to the SLA, and that is exactly what you would expect. No bone fill, because you haven't put a graft in. Or forget the graft, you haven't put a barrier in. You needed the barrier, more importantly. You need a barrier membrane for
a scaffold,
allow the clot to stabilize. So what that showed, and then he went on to kind of show in the series of articles as well, in terms of how the blood clot stabilizes around this implant surface, which allows for the absorption of the proteins, allows the absorption of the cell attachment, the bone cell attachment, happening within the first few days of implant placement. And that takes me back to my Usain Bolt and Mo Farah analogy and stuff. But here, Mo Farah couldn't, because here the hydrophobic implant surface didn't regenerate any bone after 8 weeks. Right. Because by the time the cells would have needed to attach to the implant surface, the soft tissue had already taken over. That race was won by the soft tissue.
Yeah, much faster.
So that really changed my thought process in thinking, whoa, there's something truly here. Because up to that point, as I said, I started placing SLActive. When I started placing Straumann implants in 2005, I immediately started with the SLActives, because just the SLActive was on a limited market release. And interestingly, or should we sort of say subjectively, I had noticed that the healing around those tissue-level implants was a lot nicer than I would have seen after 1 week of placement. But that was a very subjective, shall we say, observation, until these sort of studies started to come out and sort of said, okay, this starts to make some sense.
You connect the dots.
But you're still skeptical as a clinician. You think, well, okay, this is in dogs. Maybe dogs behave very differently. And they do, to some extent. We know they do behave differently. And to translate that into humans is sometimes quite difficult. And you sort of ask questions, will this really happen in humans as well? But in other words, would I do same what Frank did in dogs in humans? No, I would not. I would not just leave an exposed implant surface and not place a graft. But at least what this study gave me at that time was a confidence to sort of say, okay, if this can happen without a graft, that means that if I place a graft and place a good bone graft material and a membrane, I can speed up the process of bone regeneration. I'm giving my implant and my bone graft the best chance to have a good outcome. And that paper really then literally changed the direction of travel for me, and then subsequently my colleagues who work with me. As you sort of say, you sometimes, you have to demonstrate success for others to believe in you and to believe in what you do. And that takes time, and you have to lead with example, as I sort of say. So in my unit today, we have no hesitation in placing implants without primary stability. We have no hesitation in placing implants which need very aggressive bone grafts, because over the last 20 years, me and my colleagues have realized that we can push the boundaries. So that paper, I think I would sort of say, has been one which has really been always at the forefront of my mind. And interestingly so, because in the last 4 or 5 years, we've done more recent work, because if there wasn't much in the hydrophilic implant surface,
right,
then you wouldn't see what we are seeing today in the market. Yeah, we're seeing a lot of other implant surfaces being marketed, which are hydrophilic as well. And because of the curiosity from this, and over the time I was kind of, the sort of cases we've been doing, I was quite curious to sort of say, well, okay, are all hydrophilic surfaces the same then?
Yeah. That's a $1 million question, right?
$1 million question,
This
right?
is.
Must be, because if they're hydrophilic, and hydrophilic, by definition, is only 0 degree contact angle when you dip it in liquid or fluid.
No tension.
Yeah, no surface. Yeah, high surface energy, no tension. Is that it? Is that just the hydrophilicity? 0 degree, you prove it's 0 degrees, that is it? And the series of studies that we have conducted and published in the recent years actually demonstrate otherwise. So it isn't just that surface energy which seems to be the be-all and end-all of it. Which is interesting, because if you also see the amount of research that has been done on SLActive in the last 20 years, we have more than 300 odd articles published, research papers published on it, has also demonstrated over multiple in vitro studies, clinical studies, and animal studies, particularly in vitro studies, have shed a bit more light on the implant surface. That it isn't just, it is hydrophilic. Even if you compare the Straumann's rock solid, shall we say, if you compare the rock solid SLA to SLActive,
Right.
we now know there is a bit of nanotopography on SLActive. So there is a lot of other things happening in this SLActive surface, which isn't just about hydrophilicity, which isn't just about dip it in the blood and it seeps up the surface. There is nanotopography, which is allowing a very different kind of an interaction between the protein cells and the blood clot at the very early stages. We know that the SLActive implant surface has got anti-inflammatory properties. We're at the moment conducting some in vitro studies comparing some of the hydrophilic implant surfaces, and surprisingly, we can see a cascade of anti-inflammatory cytokines in SLActive surface, whereas we see a cascade of pro-inflammatory cells attaching to the other hydrophilic implant surfaces. So, ain't just the 0 degree contact angle. So there's more to it, and it's fascinating because the animal studies that we did, and interestingly, Frank's study is on the dogs,
Yeah.
and the study that we did, it was on mini pigs. And if I show you the histological specimens of our SLActive surface, you would think I have copied and pasted them from Frank's study. It was such a, when you're kind of doing research and thinking, I wonder what histological specimen I'm going to get, because, he's published 20 years ago. And honestly, it looks like copy and paste.
Copy paste.
Exactly the same behavior where we left dehiscence defects of hydrophilic, hydrophobic, and one of the other competitor implant surface. And the SLActive surface had the same behavior. Then we repeated the study with bone graft, particulate bone graft and a membrane on top, and the successful bone regeneration was fascinating.
Yeah.
Bone implant contact in 8 weeks in a mini pig, fascinating. Whereas one of the other implant surfaces we were testing, which is supposed to be hydrophilic, beautiful bone regeneration for the GBR, but no bone implant contact with the surface. Right. So what happened as a result of those studies, it raised more questions than the answers we had. Because now we're getting confused, thinking, what is going on here? Because, so we've gone back to doing some in vitro tests, to look at cytokines, to look at what sort of immune response you're getting around those surfaces. And there's some work done by Rene in University of British Columbia. And we have gone back to more or less recycle what he's done, where he had shown the behavior of the anti-inflammatory behavior of SLActive compared to SLA. So we're now comparing different implant surfaces,
right.
And that's where we're noticing that there is the SLActive surface is very anti-inflammatory, which is what you need, whereas the other implant surfaces, including the SLA from Straumann, is got a bit more of the pro-inflammatory response.
Got it.
And I think that's where probably the difference lies. Not probably, I'm getting more and more convinced now that we got those basic science experiments that is where the difference is. It's not just hydrophilicity, it is not just roughness. There is a surface chemistry is such that you're getting an anti-inflammatory response early on within the first few days, and that is going to be the trigger for that fast-track osseointegration. We're extending that. Am I talking too much?
No. I'm loving it.
Interestingly, what we're doing at the moment, we have a clinical trial running, and we're extending that experimentation to not doing those in vitro tests just on the the plasma and stuff that you can buy in the market. We're using the blood and plasma from each individual patient who's having that implant. So patient-specific immune testing.
Yeah.
And we don't have the results yet, but I'm really, really curious to see whether individual patients will respond differently to individual implant surfaces.
Wow.
That would be great.
That would be great.
Yeah.
I think that will also set the stage for when we look what's next, right?
Exactly. Because, the tissue engineering science is, getting more and more advanced.
If host factor is a factor, how about we tackle that one too?
Patient-specific.
I love it.
Yes.
I love the angle you brought to this because I asked you an article that was meaningful, either open your eyes to something or made you change the way you see or do something. And I like how you spin in this in a way that it started with observational elements that we all have in the office, something that we can just not explain, something that we say, oh, but I cannot just tell people it works in my hands because that's not.
Yeah, I mean,
they will say, "Oh, yeah, tell me something else."
Yeah, whatever.
But how you brought this, how the evidence helped you reassure that what you were seeing, you were not alone.
No, yeah. I mean, it started to make sense why I'm observing what I'm observing.
Excellent.
Right. I'll give you another example. Yeah, this is 2009. I had a patient fly in for treatment from Nigeria. And I was extracting an upper canine and placing an implant in the same visit. I extracted the canine. The length of the root of that canine was longer and bigger than the longest implant that I had. Yeah? So I've extracted the tooth and I take this implant and it's really just dangling in that extraction socket. And I'm left with three choices, essentially. One is just abort and do nothing. Two is don't place the implant, but place a graft in the socket, do the ridge preservation and come back. And three is place the implant and take a punt on it. Yeah? But a calculated punt based on what I have noticed with SLActive. So in conversation with the patient, I said, hey, listen, this is the problem we have. Now I said, I've already opened my implant. It's going to be a waste. I'm going to put it in the bin anyway. These are our options. What do you think? Because you've got to involve patients in decision-making sometimes.
Yeah,
right?
It's a teamwork.
She goes, what do you think?
You got to involve the doctor back.
I said, I would personally sort of say, we place it, and for our unit, for me, the prosthetically driven implant placement is sacrosanct. It's about anything in implant dentistry. We'll never compromise the position of the implant for the sake of where the bone is or where the bone isn't or where the implant needs to go. So prosthetically driven placement is absolute must for us because there's one problem you cannot fix is when you get an implant that is malpositioned. So I am now left with this problem of this big socket and having to place an implant in prosthetically driven position, which can be anything. I said, I'm going to scraped a lot of bone using Professor Boozer's technique. That's what I use for my GBR and have used it for more than 2 decades, is taking a lot of bone scraping. And I use the bone to position my implant in that socket in the ideal position. Yeah, but it's literally dangling. Yeah, and then there was a bone defect on the buccal wall as well, which we regenerated like we normally do, and I submerged it. And the patient went back to Nigeria, and she came back after 3 months for the second stage surgery. And I was pretty convinced this implant has to come out.
You were ready to take out.
I was ready to take it out. I took a radiograph when she came, and the radiograph looked good, but you can't judge osseointegration truly on a radiograph, right? And it probably was the only time when I was nervous doing a second stage surgery, knowing that I'm going to pick this implant out. Yeah, and then I had to clean the mess that I've created in there. And I go in there.
And start all over.
And I opened the flap and tap, absolutely brilliant. And that, for me, was another watershed moment in terms of questioning how important is primary stability in cases where we can protect the implant from macro motion.
Right.
Yeah, that's important. Of course, immediacy, you need good primary stability.
You submerged it.
It was completely submerged. Yeah. So as long as with a implant surface like SLActive, I know all I need is about 2 weeks to start to get the bone to get the secondary stability. Yeah. So because the process is much quicker, I'm giving the best chance for this implant to integrate. And since that day, primary stability has never been a stopper for us for not placing implants. But what has happened now of course, it was always more difficult to achieve primary stability with tissue level implants because they're passive design implants. Right. And, you know quite well that I am a big tissue level user. Bone level very rarely comes into our clinical indication. So with the new generation 4 tissue level designs of TLC and TLX, the big issue about I can achieve now enough primary stability with a millimeter of engagement of the apical part of the implants.
So you can get the best of both worlds.
I am a happy man. The TLC design, the tissue level taper design, it is. I feel it's been a big change for us, because now, with very little, couple of millimeters of engagement, 1 millimeter of engagement of the apex, we've got enough stability. Nobody wants to place implants without primary stability. Yeah. You don't choose to place implants without primary stability.
That's not an option.
It's circumstantial, as they sort of say. The only choice is either you abort and don't do it, or you have the confidence of the tools you have, the implants you have, the surfaces you have, and you do that. So it's a big kind of leap of faith, shall we say? So when we talk about, because the first when somebody goes to study implant dentistry, the first topic they teach you is primary stability. After they do the surface and the history and stuff, the first thing they teach you is primary stability, and it is such a big, underpins everything. And then when we demonstrate cases and stuff that we have done successfully without primary stability, it takes a leap of faith.
It does.
Now, I really, honestly, Christian, I couldn't tell you. I couldn't answer if you asked me a question, what would you expect the same results from other implant surfaces? I can't answer that question. Because I've never tested it. So,
I really like this example you cited, because the literature is quite fast, correlating also lower primary stability with implant failures. But there's not quite a consensus whether higher torque values will have an impact on failures as well. We have common sense there will be less vascularization in initial period, depending on the region, less vascularization, for example, in the lower anterior zone, harder bone, higher turnover. You you don't want to compromise the limited vascularization you already have. So you have to be more cautious. Common sense should be predominant. However, right?
So we published a systematic review last year on the same subject of primary stability. Now, what is interesting to note is we looked at two things. We looked at insertion torque of about 35, and we look at an ISQ value of about 50. There is no correlation between the higher the insertion torque, the more successful the implant. On the contrary, like exactly what you said, the higher the torque value in an avascular bone, the more those implants fail because of you get the pressure necrosis and stuff.
Right.
That is absolutely certain. Yeah. So therefore, all of those studies that you look at from the implant outcomes and the studies that have supported their data with insertion torque or ISQ values, there is absolutely no correlation between the lower values of insertion torque or ISQ to higher failure. So I asked the question, where is all this? We talk about evidence base.
Yeah.
There is no evidence to say if you have low primary stability, your implant will fail. I again repeat myself, it's very important that those implants with lower primary stability are protected from macromotion.
Right.
That's the critical thing.
Yeah.
We published recently an animal study. Yeah. We did a mini pig study comparing SLActive and SLA. Implants were placed with normal preparation of the osteotomy. So you get normal preparation, good primary stability, high insertion torque. Implants sites were over-prepared, and the implant was press fit. They were literally dangling in the osteotomy site. So we have normal preparation and over-preparation, SLActive and SLA. The results were fascinating. When we look at the SLActive, so none of the over-preparation implants failed. So everything integrated. This is in a mini pig where you can't control, you can't tell them, hey, don't show on that side, yeah?
Soft diet.
You can't control that, right? So, but what was really, really interesting is, I would urge people to look at that paper and see, because it will help them rethink their osteotomy preparation for the benefit of the patients. Between SLActive and SLA, if you look at 2 weeks, you see a lot more cellular activity in SLActive between the implant and the clot and the bone surface compared to SLA. Number one. So that confirms everything we know about SLActive in terms of the speed of early engagement between the host and the implant surface. Number one. Number two is the top 2 millimeters of the implant, the coronal part of the implant, which I would consider the most critical part of the implant, yeah, in terms of aesthetics, in terms of long-term stability, in terms of where all the evil stuff around the implant starts, is the implant abutment junction.
Right.
All the ones that were normal preparation implants had coronal buccal bone loss. Yeah. And in over-preparation sites, there was a thick buccal plate in those implants. Now, what does that tell us?
At the coronal.
At the coronal top 2 millimeters of the implant. That tells us that compressing an implant in, particularly in the coronal 2 millimeters, because the buccal bone is usually thin, it's cortical, that, squeezing that implant into our osteotomy site at the top, which compresses the cortical plate, leads to bone loss.
Yeah.
So, and therefore, when there is no compression on the bone, they really respond a lot more favorably. Yes, they go. Whereas if you crush someone, like something, they don't behave normally. Yeah. So what does that mean in clinical translation? It means you aim to achieve your high primary stability from the apical part of the implant and the middle part of the implant, but please slightly flare your coronal preparation. Even if your implant is not in full contact with the bone, that's better than crushing the implant in.
Right. I love this. You hit the nail in the head, because if you look at all the sites, not immediate, of course, but take a tooth out, soft tissue starts to protect. And then over time, that side is not painful anymore. Patients start chewing on it. You have the buccal bone, poorly vascularized, starts collapsing, and you have normally this teardrop healing pattern. I honestly could never understand implant designs. They start in such a way and they flare up.
Yeah.
But from the middle of the implant, where the most critical converging area of the bone is coming together and the implant is pushing. So you already have this bone that has been already traumatized by the drilling process. There's trauma, no question. They will need a turnover and remodeling just by that fact. And then you squeeze that cork.
Yeah, because people the insertion torque. I want an 80 Newton insertion torque. It's counterproductive.
It's counterproductive.
It's counterproductive because you are getting a lot more osteoclastic activity because you're crushing the hell out of those bone cells. You need to be gentle. So in the mandible, for my standard parallel implants, I would always tap the implant site. I want my implant to go in easy rather than really having to crush it and force it.
I see.
Now, if you look at some of the implant designs, I mean, I'm not a big bone level user. I very rarely use a bone level implant. But the BLX implant, and I think there are some of the other implant systems that taper at the top, which is actually probably one of the best implant designs you can have. At the top 1 millimeter, they become narrower, so there's no pressure on that buccal plate. And I would certainly sort of say, you may not have every design like that, but you can modify your osteotomy to just flare the coronal 1 millimeter, 2 millimeters, so you're not crushing that bone. And again, at the last ITI conference, there was one of the systematic reviews and the consensus statements. I was part of that group as well in the consensus statement, where the need to increase the thickness, what was expected until that point was we need 1 millimeter of bone on an implant. And on that consensus conference, it was increased to 1.5, 1.8 millimeters.
I see.
Because we need that thickness of bone. More cortical the bone, it's hard wood. It doesn't respond as well.
Shak, I regret to inform, but our time is up. I could spend all day here discussing with you. It's a delightful conversation because it's not only about the surface, it's everything that it enables for us, peace of mind, workflow, and also as an end result to patients. You brought to the table the evidence, your personal choices, how this has impacted in certain ways, even in challenging situations where you have a floater there, you're zero torque.
I call it a dangler.
Your zero torque implant, your canine floater.
Yeah.
I love this very much. Thank you for participating in Straumann Pro Talk Clinical. It was a delightful conversation.
Thank you very much, Christian. Thank you for the time. Really enjoyed it.
Thank you. And to all of you interested to learn more about a SLActive surface, stay tuned for Professor Shakeel Shahdad lectures, publications. It's worth your time. Of course, all the articles we mentioned here, we will leave it in the description below in this video. The first one we asked and the other ones that we highlighted, we will leave it all ready for you to just have a delightful reading. We thank you very much. Celebrate with us the 20th anniversary of SLActive Surface, a surface that has redefined the way we do implantology and think how osseointegration should move. Until the next episode, see you then.